During the last 10 years, there have been a lot of trials testing several drugs trying to improve the benefits of sorafenib. All these trials have been negative until recently. So we have several studies testing sunitinib, erlotinib, linifanib, and other types of drugs in front line and in second line that have been negative. Very recently, during the last 1 year and a half, luckily enough, we have 3 trials showing positive results. The first one is lenvatinib, that is a multikinase inhibitor, was compared head-to-head to sorafenib with positive results in non-inferiority. So we have a new tool, a new treatment for patients in frontline advanced HCC. Then in those patients progressing to sorafenib, that was the other scenario for which we did not have any drug. There are 2 drugs that emerge as positive trials. One is regorafenib versus placebo, and the second one, precisely in this meeting, is cabozantinib versus placebo. Beyond that, we also had the approval of a checkpoint inhibitor, nivolumab, that was approved based on data in a phase 2 single-arm study of 280 patients with good signal of efficacy. The current unmet needs in HCC are as follows. In terms of adjuvant treatments, we don't have any adjuvant therapy effective, despite that there have been 15 randomized controlled trials testing all types of drugs. And this is an unmet need because 70% of the patients undergoing resection or local ablation present recurrence at 5 years. Therefore, we need drugs in this scenario. Second unmet need is in intermediate HCC, patients with liver-only disease. We only have chemoembolization that have shown to improve survival. So we need alternative to chemoembolization or combinations of systemic therapies plus chemoembolization. And certainly in advanced stages of the disease, despite these new drugs that recently have emerged as effective, still we need to try to achieve long-lasting responses and ideally some percentage of cure. And we are far from that at this point. So these are the most important. The most important unmet need in frontline is to improve the outcome of sorafenib. So sorafenib is providing very efficacious effect in terms of improving survival from 8-month median survival for the patients at that stage to 11 months. But this result, despite that is encouraging, needs to be thoroughly improved. So the first unmet need is to try to improve the outcome of these patients and to achieve higher survival rates. The second is to try to identify drugs that are also well tolerated and which adverse events are manageable. Of course, sorafenib, luckily enough, the adverse events are quite manageable, but still 15 to 20% in some instances of patients do not tolerate the drug, and therefore we need for alternatives. Predictors of response of sorafenib and lenvatinib are not extremely well defined. But for instance, for sorafenib, we already know some clinical predictors of response. We recently reported a meta-analysis of the 2 randomized controlled trials testing sorafenib versus placebo. And in these studies, we identified that patients with hepatitis C virus infection related to HCC and those patients with liver-only disease without metastases are the ones that achieve better outcome with sorafenib. Just to say that the median survival for patients with Hep C treated with sorafenib in the trials were 14-month median survival as opposed to the expected 11 months. In lenvatinib, the data is more recent and only we know the subgroup analysis of the trial that was presented, and we can sense that those patients with more aggressive tumors, for instance, patients with high AFP levels or patients with macrovascular invasion are those responding better to lenvatinib. So we're in a scenario in which we have two drugs for frontline, and eventually they are targeting, despite that they are efficacious in all the populations, some of the patients may be more suited for sorafenib, and eventually others may be more suited for lenvatinib.